Welcome back to the Tomb, everyone. This Tomb Talks with the Pharaoh. You already know who it is. And for today's episode, it's called Publicly Healthy. And I have a very important guest with me, and I'll have her go ahead and introduce herself.
Thank you. Hi, everyone. Thanks so much for tuning in. My name is Adrianna Boulin. I use the pronouns she and her, and I'm so glad to chat with you all today. My work focuses on authenticity, healing, health equity, and community engagement. I practice as a public health practitioner and really applied that into my work that has spanned broadly across a lot of different projects. And I'm excited to dig into more of those today with y'all.
Well, let me first off start by saying thank you for agreeing to come onto the podcast. We've known each other from back in the old days, and it was interesting when I found out that you were in public health as well. I was just like, oh, it's like it's starting to expand. Public health is everywhere.
It really is. I feel like you can find it in anything. There are little um there are points of building good health in every aspect of life, I feel like.
Yes, and we're definitely going to get into what does it mean to be healthy.
Yeah.
Um,
Okay.
but I wanted to first of all just kind of get your origin story. Is that, like, how did you get into public health, and like what led you to the position that you currently hold right now?
Oh, it was such a journey. Such a beautiful journey. I always wanted to help people. And so for many years, and what I started pursuing when I first went to college was to be a doctor, studied biology. I wanted to be a pediatrician at you as well. I wanted to, I wanted to be a pediatrician, and I loved that was all about. And I did a service learning trip to South Africa and Eswatini, and it was focused on engaging with people who were impacted or affected by HIV/AIDS. And going to those countries for the first time showed me that there were different things that impacted someone's health beyond what they received from a medical doctor. It was where they were living. It was what the food they had access to. It was what their family unit and makeup was. It was um, the forecast of their political climate. There was just so much impacting. And I thought, wow, I don't know if what I'm studying is actually giving me all that I need to do all that I wanted to do. And I didn't know all that I wanted to do, but I'm like, I think I want to do more than just being a doctor. And I didn't have the language for public health. I wasn't exposed to that. But what I was feeling in that time was public health. And so what I did to nurture that thought and curiosity was I double majored in the political science field, international studies in particular, because I thought, okay, I can continue learning biology and also understand what's going on in someone's community, in their country, and how that impacts their socioeconomic status and what they have access to. So I felt like studying those two paths really gave me the foundation for public health. And so when I was graduating, it came time to pursue different routes. One of the routes that I pursued was getting a Master of Public Health, which was an amazing experience. I went to Northeastern University in Boston. And what I loved about going to Northeastern was when I went there, the program was young compared to other programs in the city, the Harvards, the Tufts, etc. And what I liked about that was I felt like I had an opportunity to mold the program and really get what I wanted out of learning in that program. And so while I was there, I did a lot to learn about what my exposure to HIV/AIDS when I was in that learning and community and what they experienced when I was in undergrad inspired me to want to learn more about how other countries were impacted in that way. Jamaica in particular, because my family's Jamaican and I always want to understand how to learn and give back to my country. And I went to Kenya. And what I was doing in these two countries was understanding what people believed their risks for HIV was and how to prevent it. And what I was learning was that what people believe is directly connected to how you've grown up, what you have access to, what's in your environment. And that relates back to how you're able to build your health.
Yes.
So amazing. I when I graduated, I started working, and my first role allowed me to really build myself as a professional. I wasn't directly within public health. I was actually working in data science. So, completely data science related to public health studies, which showed me, it helped me appreciate how data is collected, how it's analyzed. And that skill was so important for me to
Mm.
respect my colleagues who I work with that do that. I was guided to the role that
Because
I'm in.
it's a lot of data.
Listen, it's so much data. And when I was doing the work in my mind, I was like, oh, I can just, like, it's just easy. You collect it and then we have the answers. It's not like that. There's
No,
so many pieces involved. And I needed to
some
see,
data sets have 15 like thousand entries.
and it's like there's so much you have to do to maintain the integrity. And how do you um analyze that information? There's so many different perspectives and things that you have to take into account. And so that helped build my understanding of the um nuance and complexities of data. And in the role, and that was at the Brigham in Boston. In Fenway now, at Fenway Health, it's a community health center. And how I got there, just following my flow. One of my friends from high school, Zach Schwartz, he posted on his page, come to this jazz fest, learn about HIV prevention and meet people, free food, all the things I liked. I brought my entire family. And like, I love going to tables and talking to people and picking up free stuff. And I got to the Fenway table and I learned about the work that they did and the roles that might be available. And from there, it's history. And it was just so, there's so many synchronicities. One of my mentors was the neighbor of my supervisor when I first went there. And there are just so many other connections to the work. So I feel like I was very much guided into public health and guided to the places I needed to be to really nurture that understanding of what public health is and help public health grow.
Wow, that is a journey. That is a journey.
Well,
I
still
I
going to,
excuse me.
still going to.
Yes. Oh, it still continues. This is
Yeah,
just the latest step in the journey.
exactly.
But I definitely can relate to the start of it
Mm,
because um, I started pre med, then I went into biochemistry and microbiome, and I thought first, oh, I'm going to be a doctor. I'm going to help people. Then I thought, oh, I'd work at a bench. But then, like you said, I didn't have the vernacular of public health,
mm-hmm.
but I realized this like I wanted to help, like nothing against doctors. It's like, but it's individual. It's like I'm helping one person at a time. Where public health is like you can help or impact an entire community.
Yep.
And so when you decided to go pursue a master's in public health, did you have someone that kind of pushed you to do that, or were you just going down like a rabbit hole of just
Listen,
looking at things?
great rabbit holes. I applied to PhD programs. I applied to PhD in population health and MPH. I was looking up keywords for like, these are the things I'm feeling and I'm interested in. And I think this program, like I, I didn't have mentors in public health until I got to graduate school. What I love though is I very much feel like, or I hope that I'm a mentor or an accessible mentor of public health for people now at my alma mater and just anyone that's possible. My alma mater, Emmanuel College, just started a public health minor, which is huge because that language wasn't even in there at all. And so I would say, yeah, when I was at that critical stage of applying, there was no one that shared that language for me. Um, but when I got there, I knew it was the right place.
Yes, and so I wanted to. So you said that with Fenway Health, it's a community health center, correct?
Yeah,
So I want to ask you a question. Is like, is there a difference between public health and community health?
that's a great question. And I see public health as the study of community health. So I don't see much of a difference. Do you see a difference?
To an extent, yes.
Tell me. Let's talk about
So,
it.
so the way that my professor explained it to us is that public health, public health and community health both aim to do good. It's benevolence and beneficence. And for those that have listened to the podcast, I always make a distinction between the two. Go back and listen to the other episodes, or just go to the dictionary. Uh, but with the benevolence, it's the intention to do good, which public health and community have health share in common. It's the beneficence part that I draw the distinction of, is because with community health, you might not have the data or the theories to back up the interventions that you're doing. Where public health, it has been either tested and tried, or you have enough data to make an educated decision on which intervention would be the best.
I see the difference. I
Yeah.
totally see the difference. And I'm thinking about community health centers just in general. So Massachusetts had the first community health center in 1965 in Dorchester. And the concept of community health centers is more affordable care and more patient and community centered. But relating back to what you just mentioned about community health, I want to sit with the distinction that you just shared, because when I think about community health centers, we're both doing preventative work
Mhm.
and actively addressing inequities and disparities that are being presented. So, to your point of when something is in front of you, you can't say, hold on, let me do a clinical trial real quick and I'll come back and treat you. You have to actively. And so, thank you for sharing that distinction, because yeah, there's a difference. There's a difference.
And let me see if I can come up with the best. Well, an example that I use is so well we know about health behavior, and how there are different theories that go behind that, of like how to get someone to change their behavior. Like one model is like the KAP model, which is knowledge, attitude, and then practice slash behavior. Um, when I was studying at Tuskegee, one of my professors brought up the question where he challenged that, where it's like, before knowledge, because you can give someone as much knowledge as they want, but if they have a belief system set in place that will not allow them to accept the knowledge, a good example is um, people believe that when you get older, you're supposed to lose all your teeth. That's not the case. But if I give you knowledge and it's like, no, there are people that live until like until the end of their lives with their full set of teeth, it's hard for people to change their behavior about it. And I think where public health comes into that is having that knowledge and that theory, and understanding that, oh, we are going to have to address the beliefs first before we even give them the knowledge. So
Yeah.
community health might be, oh, we need to, like, it would be good if people knew about the benefits of keeping their, like, all their teeth. So we're gonna hand out brochures and have like seminars teaching that. But that's a feel good intention, but it doesn't have the theory to back up. And it's just like, no, this is a crucial piece that you're missing.
Yeah. Oh, such a great point. What you made me think of too is the stages of change model. The stages of change model describes these different places that we might reach people on the continuum of contemplating something and planning and actually making decisions and actually acting and then maintaining that act. And um, a lot of my work has involved engaging people in research and engaging people who were historically represented and historically violated in research, engaging them in research so that we can actually have data about what their actual body impacts are, so that we can actually make prevented active choices in the future. And so I like to give this example. In research, you might give someone a pamphlet and they'll look at it and like, okay, cool. I remember I gave someone a pamphlet and they're like, thank you. And it was like a fan and they threw it away after. And that to there, and I share this to colleagues too who do work in general where they're engaging someone,
Mhm.
where you may be able to um, support a changing of belief, or you might not be able to. And I think beliefs can be changed in small pieces. So you might give someone a pamphlet, they may have looked at it, they may have used it a fan, they might have seen a couple words. And so now it's in their awareness. Even though they throw it away, it's in their awareness. And then maybe they're watching something on Netflix a week later and it relates to whatever you shared with them. Maybe it's someone in the Netflix special that is experiencing something like cancer. And maybe you gave them a pamphlet for cancer screening. And they're like, shoot, didn't I see something on a pamphlet last week? Interesting. And then, you might send an email or send something in someone's mailbox and they're like seeing it different times. And each time it's speaking to their subconscious, like maybe this is something I can trust. What gets in the way of that, what can get in the way of that is if it's from an entity or an individual that who you don't trust. And what I'm speaking to specifically is when I've worked in the Black community, it can be really hard, especially around COVID-19 vaccines. I've done work with engaging the Black community, specifically in COVID-19 vaccines, to come in and say, hey, this is like, I'm Black. Okay, I am Black and I'm a Black person. Come, trust me. I don't trust you because of who you work for and the greater institution that that's a part of. And so it really takes belief, I think, can be really hard for the medical healthcare system to shift, because belief shifting, you have to receive information from someone and something you trust. And right now, especially in this country, there's a lot of distrust and a lot of mistrust, for a lot of valid reasons. And so I think those are some things that you have to navigate in healthcare. Yeah.
And you say trust. I would want to push the needle a little bit further to it's not necessarily trust, but trustworthiness. Because
Mm,
there are for me to trust you, you have to prove that you are trustworthy in the first place.
right.
And trust is something that you give. Well, trustworthiness is something that you earn. And
Right.
I think
Right. Mm,
a lot of time, well, in many instances, institutions have been shown to be untrustworthy. So how, and then it turns, especially around COVID-19, they turned around and it's just like, oh, well, Black people don't trust the medical system. It's like, and this is like, we just need to make them trust us. No, you need to show that you're trustworthy because
yes.
you had centuries in this country of you just being untrustworthy, giving us every reason not to trust you.
Right.
And I think when you shift that argument, it becomes the onus of the organization and the institution to do better and not for the individual to be complacent and say like, oh, like just take this and trust me. It's like, okay, if I go ahead and do that, what are the assurances that I have? Because I did a little bit of work with COVID-19 as well, where we've had focus groups. And one of the things that were a prevailing idea was if I have side effects, what is the course of me being treated for something? Because if I have sporadic healthcare insurance, sorry, health insurance, if I
Mhm.
don't have health insurance, uh, then I do my part in the community of getting vaccinated to protect all of us. But then if I'm negatively affected, is there a path to which I'm not, well, pretty much if I'm not ass out? Like, I'm like, and I think that's one of the things that were very much missed or sorry, dismissed, because it's a real fear that some people have, is that if I take this, and the whole thing around it being experimental and everything like that, and it's just like, when people hear experimental, they hear not fully tested.
Yeah.
Whether that be, whether if that's true or not, that's what you have to deal with. What, not what you said, but what people heard.
Right. Right.
So I feel what that is, that with a lot of times with the public health community, and then also with the medical community, is that they'll dismiss people's claims if, like, you might know the stats. It's like, oh, it's only less than 1% have adverse reactions. They don't know that. And even if you
Who
do,
did you who How many of the people did you take data from? How do you know all of them are in there? What do they look like? Like, what are the discrepancies? Sorry to cut you off, but I'm like, and when I hear data, I'm like, and there are so many discrepancies in data. And historically, we've seen that discrepancies exist across minoritized populations around race and other identities. And so we hear that 1 or 2%. Like, what does that really mean?
and with that, I was speaking with my friend who was a nurse, and well, I don't know if I can actually say the name, but one of the vaccines.
Yeah, yeah, yeah,
Yeah, I don't know, and I don't mess with Big Pharma. They might try to kill me. Uh,
yeah.
a long life. um, but we were talking about one of the vaccines that she took, and within the mainstream media, they were saying 98% effective, 98% effective. When you actually go and look at their actual results, when they break it down by racial group, the effectiveness is different for each racial group.
Of course.
So she she's an Asian woman. When she went and looked at it, she found out there was like 68% effective, but they
Wow.
never told her that.
For
So
Asian women or for Asian people.
Asian people,
Hmm.
and they never told her that. The main thing was 98% effective. And I think sometimes is that when, with something like this, where you know people are hesitant, try to be as transparent as possible. And sometimes I believe that, for the sake of just saying we're all one, there are differences. If you find out that there are differences between Black people taking it and Asian people taking it, both groups have the right to know what their rates are,
Yeah, that's such a large jump from 98 to 68.
because it was an average. They took the average of all of the, yeah. When I went and saw that, I was just like, "Whoo!"
And it makes me think those differences exist in everything we take, all the vaccines that we take, any like influenza, like the medicines we take have varying levels of effectiveness based on the different identities and makeup of our body. And I guess I'm thinking about that now, like, wouldn't it be something for something to report it this much effective for Black people, this much effect? It would, inequity would be shouting at the world, and like we'd have to do something about it. I mean, we're doing something about, I don't want to do air quotes because work is being done.
Mhm.
um, Work is being done, and more work needs to be done. That's how I'll say it.
Yeah, more work does, like, it needs to be done. I just feel like in I feel like if they were to report it like that, there would be people that would say, "Well, why are you racially breaking it down?" And that would become the topic of conversation, um, not why are you breaking it down, like, oh, why are you breaking it down racially, not, hey, this is the result. You're allowed to make your own decisions. Like,
Mm,
if I found any discrepancies, I'm doing my job ethically as a researcher by telling you.
right,
If I tell you that this is like, even if they say, they could have easily just said this is the average, like, this is the average effectiveness for this vaccine.
right.
That would have been fine. But the way in which the health communication part of it was lacking.
98% effective, period. Because
Yeah,
we all the same. obviously. Like,
Yeah,
no.
and that's where like being well, having just graduated and just kind of
Congratulations.
oh well, no, this is back in
Oh,
2020.
oh.
Yes,
Well, then,
yes.
yes.
Well, thank you.
Still.
No, I graduated right when the pandemic hit.
What was that like? Do you mind sharing real quick? I don't know what you can say. Life was crazy then, so maybe choose something related to school if you don't mind.
Well, I got very lucky.
How so?
Some like someone in the universe, some ancestors were looking out for me because
Yeah,
with my thesis, I had to go into the school because I was studying food waste in the middle school in the middle school,
yeah.
um, and I had to do 3 days of data collection. That that Saturday after I finished, that's when the whole world shut down.
Whoa! What are the odds you're able to do your data collection before that happens? Wow. Like, did you celebrate? Not, I don't know.
Oh yeah. I drank. I drank. I was happy because that was just a whew, because that was a bullet that I just straight dodged.
Wow. But can you imagine? Not like, yes, you can because you dodged it. I'm thinking like work happening around the world, like on all fronts, and like specifically, let's think public health. Public health work happening across the world. Students, researchers, and otherwise, like stopped while we had to figure out how to do that work remotely.
Hmm.
Not.
Yeah, it was interesting going from in person to remote. Um, I know that some of my classmates they kind of struggled with the remote learning, and then people in the program when I spoke to them afterwards because they were still remote for about a year and a half after that. A lot of well, I won't say a lot, but there were people that voiced that remote learning just wasn't working for them. I'm fortunate that I was able to like I can learn from almost um, any type of avenue. So whether it be in person, remote, I'm just a sponge. But but yeah, I got really lucky with that because I remember waking up that Saturday morning to to an alert that all Alabama schools were closed,
Oh my gosh.
and I immediately called my thesis chair. I was just like, "Do you see what's going on?" He said, "Young man, you are lucky." I said,
Oh my gosh. Ah, question. So, something I'm sitting with is public health pre COVID and public health after. Um, do you think we're more progressive now after COVID-19? Not that it's done, but after having experienced the emergence of it.
"Um, more progressive, more progressive in what sense?"
Um, Reframe. Do you think we're paying attention more to public
No,
health? Ooh.
as a public, no, because like there's still people dying from COVID-19. If we were as astute to public health, most people would still be wearing their masks. Now, I'm not gonna lie, I'm a little bit of a hypocrite in that because I don't. But we know this. It takes a buy with herd immunity. It takes a certain amount to buy in for it to be effective. If 1% does it, then it's the intervention is not it's not working. Um, I think that maybe it has sparked some conversations about the inequities in public health, but I think it's just conversations as of right now. Like when COVID-19 started happening, they said, "Oh, like the black community is disproportionately dying from this." It was just like, that's not an inherent thing of COVID-19.
Right.
It's like this has always been the case. It's like it has, like, we've been maneuvered in a position where anything could have done that. Swine flu could have done that. The Spanish flu, if it came back, if it wanted to make an encore, could have done that. Like, it didn't matter what the disease was, because for the most part, with Black communities, we were living in an unhealthy state. So we're driving a car with one wheel, and then when COVID comes, takes the last wheel, then we say it's like, oh, COVID is like the culprit. No, it's the systems that were there beforehand that maneuvered us in a vulnerable position.
Yeah. Yeah, I agree. I agree. I think there's more conversation. Um, and I guess I'm stuck with, how do we move that conversation to action? That's what I try and work on in my role every day, is really moving that conversation to action. And I used to be frustrated in the work that I love my work. I love the work that I do because I've shared that my work focuses on authenticity, healing, health, equity, and community engagement. And um, those are those principles are really at the foundation of me in general and the work I do. And what I'm most passionate about is creating spaces where people can authentically be their healthy selves.
Mm-hmm.
And I think in public health, there aren't always spaces where that can be created. Um, and what I like to challenge is this idea that a system can be perfect. A system receives what it receives and it has no control over what it receives. And a system receives an individual that comes from different places, that has different experiences, has access to different things. A system receives that. And the system has to be built in a way where that individual can be triaged in a way where it can get everything that it needs. And I think healthcare systems try to do that. But I think what historically informed those systems is one idea of what a human is and needs. And I think this awareness, the more conversations that we've had that have elevated the inequities that we've always known to be true, like you've mentioned, it could have been anything. I think it allows us to address it more.
Yes, yes, to an extent, I do agree with you.
Mm-hmm.
Um, I think to answer your question, is like, what do we do?
Mm-hmm.
I think the first step is listening to the communities that you want to have an impact on, and being straight up and just transparent with them, and asking them, it's just like, okay, we'll use the COVID vaccine as an example.
Mm-hmm.
Is is not is not necessarily like, what do I have to do for you to take it. It's, what do you need for you to feel comfortable to make your own decision.
Exactly.
And I think that's a very different question, because at that point you're giving autonomy back to that person, and you can, well, you do have police power in certain public health emergencies, but for the most part, you can't force someone, or like it. You shouldn't have to force someone to do something that is beneficial for them. The best thing that you can do is address their concerns, and offer them authentic assurances. Now, you might not be able to say, it's like, oh, if you have a side effect, you're going to get $10,000. But what you can do is, if you're like a health clinic, a community health organization, is like, if you do have a adverse reaction to this, it's like, you will be seen by us. And like something like that. Now I understand that's probably,
That's enough.
excuse me,
Do you think that's enough?
that's step one.
Mm,
And it's about building the trustworthiness. It's about saying something and actually following through and having transparency. And a lot of times with just whether it be public health or medical professionals, they are not conditioned to be okay with saying, one, I don't know, or two, I was wrong.
yeah, I agree.
And I think to build trustworthiness, you have to be able to say both of those things. You have to be able to say to someone, I don't know the answer to your question, but I will find it for you.
And actually do that.
Yes.
Or come back and say, we don't know,
Yes.
which
And
is so, which is scary, right?
it is scary when it's someone that you have a perception of is like, oh, they should know all of this. And it's like, no, we don't know. That's science. We don't know everything. I can give
Yeah.
you the best information that I have.
Yeah, that's something that part of my role also is on um, community education. And one thing that I really like talking to community about is how to manage their expectations and really who understand the role that everyone is playing. And to your point, like doctors and researchers don't have the answers for everything. And we're all partners in this work. Even though there are individuals that have degrees and certifications, we are all entering this work as partners. But I do think some people look to, I remember specifically when I felt like every week there was different information that we were getting about COVID-19. And it was like confusing. You all just said this week, then you all said this. And sometimes they said this because they didn't want to say we didn't have an answer yet. So they told you something else. So, like, I totally hear you that. And it's like, where does that come from? This idea, I'm like, is that colonialism? This idea that you know everything and or have to perform as that, and then that perpetuates this idea that you do know everything. So then people are expecting that, and so when it's not received, it creates more distrust.
Yes. And I think that what professionals need to understand, um, and this is just my opinion about it, is that a degree does not give you all the answers. It gives you the tools to find the answers.
Mm,
So for me, that's what my degree did. It gave me the tools to find the answers for when people have questions. Now there are certain things that you just memorize, where it's like you don't need to go find it. Like people found it out and it's tried and tested and it's true. But
right.
the crux of the degree gives you the ability to say, I don't know, but I will find out for you.
Yeah, I love that framing. The degree offers the tools to find information, but just not the information, right? Like that, absolutely. Absolutely. I like that. And talking to community, that's something that I want to share with them too, to just help them understand again what people's role in the work is.
Yes, and I think when you engage with the community is that you have to understand, like, not you specifically, but people need to understand is that there are varying degrees of knowledge, not necessarily education, but knowledge. So when you're speaking to a community, is like be prepared for someone that will push back on something that you say on a different level than someone else. Someone might just be like, well, why is this happening? But someone else might be like, well, I looked at these studies and it says da 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 da. And just having respect for both. Because I think a lot of times is that when people get degrees, if someone asks a question in a certain manner, it's kind of an elitist type of thing. It's just like, oh, it's like, why are you asking me this? It's like,
Yeah. I've always welcomed questions, other perspectives, challenges. And when I've talked to colleagues about this who receive it in a threatening way, I speak to them about the importance of empowerment. I feel like an individual who is in a position to make informed choices for their health is an empowered individual. And so, um, when COVID-19 emerged and people had different perspectives on um, the presence of vaccine, of COVID-19, or even the effectiveness of the vaccine, I invited people to stop and think. People's perspectives are coming from some place that they trust and respect. And so them not having the space to share that is a form of disrespect, is a not a foundation to build on trustworthiness. And they don't feel as empowered to speak up about what they think. They'll just keep it. So like if you have future conversations, now people are discouraged. It's like, well, the last time I went there, it's so, I think it's so important to nurture and allow space for people to be empowered. And that comes with asking questions and having them answered. You said a while ago, a degree gives you the tools to get information. So if you have the tool to get information, and that's something that you can offer to another individual who's seeking information and they're sharing the information that they have, the best thing you can do is hold space for that.
Yeah.
So empowerment's so important.
Yes. And what's very interesting is that we've been talking this language, but we haven't really. What we've essentially been talking is about public health and public health ethics and bioethics. And like what you said is that holding that space and having that person have the autonomy and the information to make a decision for themselves. That's bioethics.
Mm-hmm.
Public health ethics is looking at, okay, how is the healthcare system interacting with the Black community? That's public health ethics, because most of the times it's that they look at it as like, well, they don't trust us. Good example, like how you were talking about with the studies when they do vaccines or clinical trials. It's like, well, by NIH policy, they
Yeah.
have to have a diverse sample population for.
Yeah.
But many of the studies that are sponsored by them, by the NIH, they don't follow that. They're not like they don't put a halt to the clinical trial if they don't meet that. All they have to do is say, "Oh, well, we tried, but this population was unresponsive," and they can just keep going forward.
What do you think should happen?
I think, first of all, I think that um, us as Black people need to be involved in clinical trials, like, because if we're not in it, we won't be represented in any of the adverse side effects. And at that point, it does become an experiment on us.
Yeah. We're taking something we have no information about how it impacts us because we don't have enough representation and study of it.
So, yes, I think we need to do that. But also, trustworthiness needs to be built on the other side so that we can meet at the middle. Because one of the things that irritates me the most about clinical trials is that if as a black man, if I decide that if I have type 2 diabetes and I decide to go into a clinical trial where it is a new drug that is supposed to help with maintaining my glucose levels, everything like that, I will get probably the best care that I've gotten ever while I'm being, let's call it, experimented on. It's volunteer. It's voluntary, so it is legal and it's ethical because I chose to do it. But I'm getting the best care. As soon as that clinical trial is over, I revert back to the healthcare that I had before, and that drug that I helped get to market, I might not even be able to afford. So you're willing to use my body when it benefits you, and I am a willing participant in it. But after that, now that same drug is used to help other people with more opportunities, more finances, better healthcare. That's
Yeah,
the problem that I have.
that's a huge problem. That's a huge problem. I've heard in some of the work and research that we've done, research participants and community demanding to learn, okay, what did you learn? What changes are happening? And the flow of research is so variable, and it takes, you have the results and it's years, and the individual who you worked with that received that optimal care for the couple weeks or month that you worked together is now continuing their life out of the care in a whole different way and area than they received when they were going through the study to begin with.
Yes. And one of the things that my professor would always tell me is that research doesn't stop once you have the conclusions. You have to take it back to the community, because there's a lot of studies that are just collecting dust on the shelves, and the community has no idea. Like you said, like they didn't bring it back. They didn't let you know like the follow up. Like, what did we find? I think as a researcher, you have an ethical obligation to tell the people that you collected data from what you found.
Yeah, I remember. So in the early days of the emergence of COVID-19 in Boston, there was this coalition called the Black Boston COVID-19 Coalition. And there are a lot of different entities and individuals from different sectors, to include health, that would come together to talk about how to mitigate COVID-19 in the Black community in Boston. And I was a member, one, just a general member, but also a representative of Fenway Health. And I remember going there and one day asking if I could present on our research study. We were doing a research study for one of the vaccines at Fenway. And the group was awesome, allowed me to share about the study, and was like, this is cool. Yes, you can share information about the study, but what are you doing about anti-racism in your organization? What are you doing on the daily to dismantle it? And what other roles have you put in your structure? Like, really challenged us. Like, cool, you want to bring this to us? We want to know what you're doing now to address what leans back to what you're trying to encourage us to engage in. So I'm thinking of that instance right now about how I would say that was a point in my career where I was really able to both engage community and be responsive to the needs of the community in the now. What we did after they challenged us in that meeting, we got together, sat down at the table with the coalition, our organization, and we said, this is what we're doing. And one of the deliverables that we're doing, our organization has a racial equity action plan. It's a 5-year plan that a team, I happen to be on the team with other colleagues and board members and staff, that came together and said, like, how do we address racial equity in our organization over 5 years in different areas of the sector and care and services? And so we shared that with them. They're like, this is cute and more needs to be done. This is what we want to know. This is what we want to understand about what builds health and wellness in the Black community. How does that align with what you want to learn? And I was like, we're trying to reach and offer quality care. I like to use the term culturally humble care rather than cultural competent care, because competency suggests you've arrived and now you know everything. Whereas to me, humility is, the world is constantly evolving. There's always different contexts. We're not always going to have 100% pulse on it, but we need to approach the work and people with respect, and be humble in that we're not going to know everything. Um, I stopped to talk about COPE, going back to Black Boston COVID-19 Coalition. So we sat down and realized we had this shared mission, and understanding like what Black Bostonians felt they needed to receive better care now, what it meant before and in the future. And we drafted a report. We did a webinar sharing our findings for the community within months of doing it. We shared it with different institutions across Massachusetts, that both health centers and major hospitals that used that report to build out their particular plans. And like, this is ongoing, because I'm like, okay, everyone read our report. We shared it with the community. They see that we're behaving differently in our work, and we're still doing that work internally. We've shared it with different organizations. I'm still waiting for the impact to hit the community. I feel like the community has seen what we've done to be continuously active and genuine and intentional about the work we're engaging them in, and the work that we're doing as an organization within ourselves to engage them in that work thoughtfully.
So let me ask a question. With that, with going with the back and forth from the community, and with them pretty much telling you, it's like this is what we actually need.
Yeah.
um, has your organization, or maybe like have you just not necessarily a survey, but ask them, it's just like, what are the main things that impact your life, and what are the main things that impact your health, and have them rank those things.
That's such a great suggestion. And it aligns with a project that we're doing right now in the community to understand what trust means and what confidence in care means. And one of the things that we're delivering is a very brief survey, and it covers there are a lot of life questions that relate to their knowledge, experiences, and attitudes. And there are questions about their thoughts on health to really get at their beliefs, to really understand just that, what you asked. But you just asked it so clearly. I'm like, we could just have a conversation and just rank it. That is so easy. And I guess really excited about the project I just told you about, but it doesn't need to be that. It could be just as simple as you said it. I'm like, wow, we should do that. Let's talk about that project later. But yeah, so have I ever asked those specific questions like that? No, although that there is a survey that we're doing. So have you?
uh no, I've like, just because when I went to school, I actually, like, I lived in the community, versus, and no shade to anyone else, some people lived the, like, next town over and would just
Yeah.
come in, take the
Yeah.
classes, and then leave. um my When I got there, my professor told me, it's like, if you're going to do public health, you have to live in the community. And I, from just from being there for 2 years, I understood, like, the things that were a problem for me. But then just being out in the community and kind of just talking to people and just like listening to things that they had grievances about, it's just like, oh, we might not know exactly what they need, because we'll the hubris of people in public health is that, oh, I study this community, I looked at the data, I'm going to come in and I'm going to fix it. And then you get in, try to do an intervention, and it doesn't work. And now you're looking at yourself, it's like, oh, well, maybe I did it wrong. It's like, no, you just never asked them what they needed. A good example that I always use is, I think it was somewhere in West Africa. They went to do an intervention with malaria, and their thing was just like, oh, well, we'll give them mosquito nets to, like, for their beds, so that, like, it would help stop that, like, stop the transmission of it, well, reduce it. When they came back a couple months later, the people there were using the nets for fishing, because malaria wasn't the main thing on their hierarchy of needs. It was food. So, if for you to interact with people, you need to know what they value, what their needs are, and what their wants.
That's like, what is important to you? What are your priorities? One of the part of my role is to also engage with different community partners and just understand what they're doing. And one community that our organization is trying to engage more is the Cape Verdean community. And our pathway to doing that is reaching out to other service organizations that already provide services, and reach out to these communities to say, to introduce ourselves and ask those two questions. What are your great key priorities? What are your greatest needs? Period. And that's so important to me, because I feel like I've been in spaces where people come in and say, this is what we can do for you, or this is what we want to do, and don't take a moment to understand what someone's greatest needs, what are their priorities. When engaging people in research, that was something that I had to really talk a lot to my colleagues about, because they're like, yeah, just go in and table at this event and let them know that we're um, recruiting for this research study. I'm like, we are tabling at a community food pantry. And so people's greatest needs in that moment is not necessarily to be a part of our research study and while I want to be there and share information about them, if they're coming to talk to me about food insecurity, I'm not going to say, okay, cool, thanks for sharing that. Here's this flyer. And so, really taking the time to understand what someone's needs and their priorities and how does that fit into what you hope to engage them in. If the answer is it doesn't, leave.
Yeah.
And like, period. And that's hard for people to like, but like, it's not for everyone. Like, we're not all in alignment with each other.
And some people just don't want to hear no thank you. It's like, I want to give you some, I'm good. Not
Yeah.
what I need. And going back to the analogy about the degrees giving you the tools,
Yeah.
no, like, you will hire a construction company and you tell them what house you want. You don't hire one and they tell you this is the house we're building for you.
Ooh. Do you have that written down somewhere? You need to write. That is so good. That is so good. That's so good.
It's like,
Yeah.
we have the tools. What do you want?
Wow. I don't know if you intended that to be really deep. That is really great. Yeah, absolutely. Absolutely. Wow. Can you imagine if providers just like really realize that they are the individuals with the tools and they're in being instructed by people, patients, humans on how to build their wellness?
Yeah.
Wow. Yeah. Their house of wellness.
And I think, I honestly think, well, I mean, I don't think it. I believe it. I know it. That a community has to define what health is for itself.
Yeah.
And you can give people the knowledge and say like, okay, this is your definition of health. Have you thought about moving it a little bit this way? And this is why. But you can't, if you want to actually connect with people, you can't go in and say, this is unhealthy, change it. As you know, it's stages of change. You need to move it very, very carefully, because one misstep and it is easy for someone to revert back to their default setting.
Yeah. Yeah. I'm like, what gets in the way of us taking our time? Because I feel like research takes a lot of research. I feel like the space to allow someone to flow along that continuum of the stages of change takes time. And I think sometimes the world is like, oh my gosh, we're just letting them know, why don't they find out right away? Like, what prevents us from taking that time? I don't know if it's our flow of the world in the United States or more worldwide, but what I'd love to see more in the world and what I want to put into the world is more patience and space and time. I feel like there are people that have a certain level of privilege for whatever identities they hold that can move at a certain pace.
Hmm.
That is not the flow of our world, and people don't have access to the same things. So I kind of went down a whole rabbit hole, but I'm so passionate about us having enough time for people to make decisions. Because I remember we keep talking about the vaccines, but I think to your point, like, it allowed us to have greater conversations about inequities that we've always known to exist. Um, but with the COVID-19 vaccines, I feel like there were people, I feel like there were people who didn't, I forgot what I was going to say about that. So maybe we'll flow off of the COVID-19. We'll
No,
flow
it's
off
no, it's fun, because I think within that is that, um, like you said, is that giving people the time and the patience. And one of the things that I had to learn as, just first of all, just a human being, but then also it's like when I do deal with public health, not so much in recent months, but when I do deal with it, is having the compassion for others that you hold for yourself. Is
that.
that most people don't change overnight. Unless it's something that's very drastic, you get a diagnosis where it's just like, if you keep doing this, like, you have X amount of like years left. But I I would I would charge professionals to say to themselves, what would take me to change, and what haven't I changed that I know that I need to, and then from there, put yourself there in someone else's shoes and understand that that same reluctance and that same type of patience that you need to change, they do. But when you're coming to them as a health professional or a researcher, you want things to be like this because I need to write this introduction, I need to get these results, I need to do all of this. And it's just like, if your main goal is the betterment of the people, then it doesn't matter how long it takes you. Now I understand that with grants and everything like that, you got to produce something.
It's just that's another system that's causing, yeah, impacting. Yeah.
So I definitely understand. I definitely understand why there is an urgency, and I guess being creative is that if we're not getting the initial data that we set out to get, is like, you still learn something along that process. You might find out something that might change the trajectory of your study, because it's like, oh, I might want to be talking about food insecurity, but it might not be that there's a lack of availability or accessibility. People just, it might be a lack of acceptability. People might not accept what is being given to them in like a supermarket or something like that. Like, so those are the things that I think people need to understand, especially public health professionals, is that within this field, there's a lot of compassion that needs to be had.
Yeah.
And it's not, and especially, and I'll say this because I'm unapologetically about it, especially us as Black people in public health, when you look at the statistics, you see us at the bottom all the time. And for us, those aren't numbers. That's my aunt, that's my uncle, that's my brother, sister, that's my mother, father. Those numbers have their own stories behind it. So we need to understand this, like, to engage with that community, we need to first understand, empathize, and have compassion first. And then that's when the actual learning and understanding happens.
I so agree. There's this training that I lead for providers and researchers, and it starts off by inviting everyone to answer questions. What motivates you? What challenges you? You just mentioned one, something related to like how much time does it take you to change or something like that. I'm like, I should add that to it. But it requires, I've noticed like people aren't grounded in the work, or like it's work and it's numbers and you're not seeing it's a human, just like you are a human, and what it takes time for you to understand and accept and decide on is the same process, maybe in a different way, but the same process that everyone has to go through in their own way. I think even myself as a researcher, I feel very grounded in that now. But when I first graduated, um, let me not say that. I think I've always had a level of groundedness and understanding that, especially compared to colleagues. But just there was a time where I was so in the work. So I guess what I'm showing compassion, I that those questions allow people to be grounded and experience and feel compassion and empathy for the human experience that they experience themselves, so that they can understand that work more. And I'm also showing compassion for individuals like researchers and providers who, for a variety of different reasons, are in this tunnel of like work, and like therefore don't see that your work is with people. People see that, but just really understanding that and feeling that like this number is, to your point, your mom, your aunt, like that would put that work in people's heart space. And I think people aren't always in their heart space when they're doing research and work as a physician, etc. They're in their mind space, like, went to school, got these tools, I'm thinking and receiving and accessing information, and you're doing it to support a human being. um yeah, that compassion is really, really important.
And you said that you lead you lead like a class about like with
A
research.
training.
Oh, sorry.
Yeah. Yeah.
Um, obviously, not telling you how to do your job.
No, I'm like, I'm here for it. Let me know. Let me know.
An exercise that I just came up with that might be interesting, maybe impactful, is that having like looking at the group, looking at the individuals, and just writing down like pretty much treat them like statistics. So you're not so and so. You're white male, 65. I'm gonna speak to you as that. Like I'm not gonna say your name. It's just like white male 65, like white male 34. Like and that at that point they understand what it's like to be spoken to as a statistic.
Wow. Oof.
That's gonna be
Yeah.
a, it's gonna be a rough day.
Thank you for offering that. I'm like, that um that drives the point. It brings, I remember I was doing a presentation the other day, and it was on Black HIV/AIDS Awareness Day. And I was opening the presentation and I was asked to share um, statistics about HIV in the Black community, one of which is that 1 in 2 Black gay men in America will be infected with HIV if we continue with how the world is going right now, among many others. And um, now I'm like, I probably shouldn't have said so many. It was important to share with people, but it was so heavy, and it was heavy in general because I don't just see statistics, I see people, but we were also talking about Black people. And after I said all those statistics, I stopped and I said, I'm going to invite everyone to take a moment to just sit with and process all those statistics and all the individuals that represents. And someone else on the panel was grateful for that time because they were like, these are my aunties, my uncles, my cousins, the people I look forward to. So, ooh, thank you for offering that exercise. Yeah, because people will say, yeah, everyone's not a number. I realize that, but when you just did that exercise, I felt it. Like I feel it when people are doing it. Thank you for offering that. And if you want to do that as a training yourself, do it, and please like market it, and I will buy it from you or use it whatever. But like that's yours, okay? I will give you your credit. That will show that, and I'm here for those moments in rooms when people are like, "Oh, this is uncomfortable." Yep, this is how the world feels.
Hey, that's yours. That's all you're out there in the field. So the tool I'm giving you one of my tools.
Thank you. Received.
No, but it's I think it's very like with that it drives home because a lot of times people think, oh, I think I know how that feels to. It's like, but until you're actually like spoken to like that, then you really don't understand how dehumanizing it could be when someone speaks to you as a statistic. And it's completely different from just stating the statistics. But if I'm speaking to you and it's just like, oh well, you know that 85% of black people have da da da. So I'll give you a good example. My well, he probably doesn't care. A family member, yeah, I'll do that. A family member that I have has type 2 diabetes. And when he found out about it, the doctor that he first went to, he told him was like, oh, well, your test results came back. It's like you have like type 2 diabetes, so we're gonna start you on insulin. The person looked at him and was like, well, I don't need to be on it as of right now because it's not in the levels to which is it's like, well, and then the doctor responded, well, you do know, but like 85% of black people have the, and at that point, that person got up and left because they knew that it wasn't, you weren't looking at them as a human being. You were looking at them as a statistic. It's like black person, this age, type 2 diabetes, give them insulin. It's like you're not looking at the person, you treat them as a statistic. And
Right.
unfortunately, it's like I don't think enough of our people have that type of autonomy to be like, I don't need that doctor. I'll go see someone else that actually respects me. Because most of the time, it's unfortunately when we do interact with the healthcare system, it's in points of crisis.
Yeah, and everyone, that reminds me of the empowerment piece again. Not everyone is empowered to make that, to stand up and say, I'm not going to deal with this. Not everyone is empowered to challenge what a doctor says to them, even if they're like, I don't think I need to take it right now. Not everyone is empowered to make those decisions. I was having a conversation the other day with someone, and we were talking about care. And when you receive care that is not affirming, or for you the individual is like, that happened to me and I got right up out of my seat and I left and I found another doctor, and people need to do that more. And it sparked a conversation in the room about what allows people to access that power to get up and get out of the room. Does your insurance even qualify for someone, for you to see someone else? Like, do you even have the capacity and access to call and stand on whatever long telephone line or email and endless fax over this? There's so much that goes into that. So I was just thinking about that as you mentioned that example.
And
Um,
unfortunately, sometimes it's the privilege of audacity.
Oh, and like, how do you build the privilege of audacity? What does that look like? Well, I feel like I'm assuming that this is something you're suggesting can be built. Is that correct? The
Yeah.
privilege of audacity can be built.
Yeah.
Can you share how it can be built?
Um, I think one, and it's probably just the nerd side in me, is you do your own research. And sorry, I have to be very intentional about my words. Not your own research, but find find your own information
Mm,
and be and confident in the information that you have. Be able to question even be able to question your doctor, be able to question what you find on the internet, read some research papers if you have time for it, or go to competent and trusted people. And someone who is trusted might not be competent. I like some people are heavily in the church. You might go to your pastor and they might not be competent in type 2 diabetes and what that looks like and the certain things that you should be able to do. Go to the
yeah,
people that are trusted, that have the information or have the tools to get it for you. And then when you want to engage in the healthcare system, you're not you don't feel like there is a imbalance of power. Because I feel a lot of times, going back to
mm,
what we were saying, we assume doctors know everything. So I'm going to you for answers so I don't have power. You can be ignorant and still have power.
yeah, yeah,
And it's on the onus of the people providing the care to understand that you might be dealing with someone who doesn't know. And you might have to take the time to explain it. But that's where you see them as them and not as a number, not as a statistic. So I think
being,
that's how you build audacity.
thank you. The privilege of audacity.
Because a lot of times people will be like, "Who do you think you are?" I'm me, and I'm affirming that. One of the things that my professor, he's great. He drops so many jewels for me. I just keep
Yeah,
passing it forward. He he said that there's something spiritual in the word no,
I'm learning that.
and in a lot of facets of our lives, we we will assert the word no, but I feel like when it comes to healthcare, because we don't have the education that another person has, we're not willing to assert that same type of boundaries because it's like, oh, this is good for you. Well, okay, they said it was good for me. If you're uncomfortable with it, you have the autonomy to say, I won't do this until I'm comfortable.
That's available. It's available. What do you think prevents people from not reaching it? That autonomy. It's available. What are barriers?
Um, Hold on. I thought this podcast was supposed to be was.
I know. I know. I'm like, okay. Let me. I know.
I'm
You
just
can
messing with you.
mention that, but like, um,
Um, the barriers to it, I really do believe that it is first of all the beliefs of when you're interacting with healthcare professionals. It's the belief is that they have all the answers and that they're right. And then the second one is the knowledge of whatever you're going in for. Like I've understood from a very early age that they're not always right, but then also I will also seek the knowledge before I go in there. It's just I'm about 9 for 10 when I go into a doctor's office. It's like, yo, this is what I have. And at this point, I feel like if I tell you what I have and I'm right, I shouldn't have to pay a copay. Like,
if it only could work like that. If
yeah.
it only could work like that.
So I think those are the two things. And it goes back to what we were saying, belief and knowledge and just having the belief that, well, dismantling the belief that because someone has a degree, that means they're right. Now, that's like might be a little bit reckless to say because then at that point, like people will say like, "Oh, you're stopping people from going to the doctor." No, go to the doctor, but when you go there, be intentional about why you're there.
Yeah, and be curious and be comfortable with being curious.
Ask
I
questions.
agree.
Yeah.
Yeah. So like thank you for answering the question about barriers. I when I think about barriers, I also think beliefs is a barrier and I wonder what is it that frames the beliefs? What's at the root of a belief forming? And I think it's so much. And I think at that point, because that's the point of intervention that I like entering at. Like, what is framing someone's belief? It's what you've been through, it's what your family has been through, people you know have been through, it's what you hear, it's what the people you trust. You mentioned like, you know, the pastor at your church may or may not know, but that might be who you're listening to. So that was a path that we had taken with one of our interventions. So we started doing education in churches and we connected with the Black Ministerial Alliance to engage with others. And so belief is a barrier. And it's like there's so much of the belief we can control. The person can. What do you? I think I'll say. I'm curious what you think. I think there's only so much of a person's belief that we can control. What do you think?
No, I agree with you. What
Oh.
what I was going to say is because you asked, it's like, where does this belief come from? So do me a favor real quick. Just close your eyes for
Yeah,
a second.
yeah, I like this.
Now, I want you to think of a doctor. What do you see?
Black man.
You are an outlier.
Really? And you know what's like? I really did. I'm like, I'm kind of surprised, pleasantly surprised. I
But
don't know. Like
why are you surprised? Because do you know that most people, when they think of one, they think,
a white person, likely a white man.
and where we have been conditioned that, oh, a white man knows, like, like, we've made it like, knowledge and knowing has become synonymous with whiteness.
Ooh. Oh, yeah. Yeah.
So we're not going
Yeah.
to train with a white doctor.
Yes, exactly.
And for the most part, most times, I mean, it's getting better. You're dealing with either like you're dealing with a white doctor or a doctor that doesn't look like you. I think that's where we start like having confidence in ourselves that we can produce people that know just as much or more.
Yeah. I remember the first time I ever got surgery and was put under, I was like all types of worried. And it's so, it's almost making me emotional think about it. I remember I got wheeled into the prep room and the entire team, except the anesthesiologist, but the entire team were Black women. The doctor, the nurse practitioner, the nurse assistant. I was like, am I in heaven? It was so, I was
I
just
know
like,
I'm in good hands now.
listen, I was just like, I'm ready for anesthesiologist knock me out. Like my girls got me. Like it was so just, yeah. It makes a difference. It
Yes.
makes a difference.
Quick sidebar because
Okay, no, go ahead, go ahead, go ahead.
you brought up going into operating room. Um, I ended up having when I was younger. I think I was 14. I had surgery on my hip. Uh, had they put two screws in, so of course they knocked me out. And just to show you how optics sometimes can just dictates how you react. Uh,
Yeah.
so surgery goes on, whatever, and they put me in the recovery room. They come out and get my mom and was just like, "Oh, we need you to come back here. Like he's fine, he's in recovery, but need you to like come back." She comes back. I'm curled up in a ball with the sheets over me, and I because I just had surgery on my leg, like they need me to straighten my leg out.
Yeah.
And they tried. Apparently, they tried hard to like get me to. And I was strong at that point, I guess. And my mom comes over. She was like, "Hey, son." I was like, "Who's that?" "It's your mother." So I look out. I was like, "Oh, come here." I put the cover over it, and it's just like, "What's going on?" I was like, "Mom, I woke up and I saw nothing but white people."
What did I wake up into?
It was like, "Oh, the surgery didn't go well."
Oh, no.
Yes, and I remember I remember asking her about it, and she said it took everything within her not to laugh because it's like you need to straighten out your leg. It's like I needed you to be fine first before. It's like why are you cracking jokes? But yes,
That is so. Did you straighten
having a team around you is like depending on what it is, it can change like how you see things. Now, granted, I was probably still high off the anesthesia, but I woke up and saw nothing but white. I was just like,
this is right.
it's like there was definitely some color in here before I went to sleep. So,
Explain.
so
That like
then wake me up.
what right? I'm thinking about what you described that you did when your mom came, like actually bringing your mom into the sheet. It's like there was a safe space that you'd created and you didn't pull down the you brought your mom into that space. And it's like having someone else that looks like you or just expresses something that you can connect to provides that opportunity at safety.
Yes,
And that's that opportunity at safety, both physical and psychological, is like where wellness can be built. And so when individuals do not feel like they have a space of safety, there's less of an opportunity to build to to build wellness. I'm thinking about an intervention that we've done that we're working on where we were thinking about putting putting rapid HIV and STI testing machines at in non-traditional locations, or not in non-traditional locations, in health centers across the state. And someone in the community was like, look, Whether you put a rapid machine there for me to do something quick or not, long story short, I don't like walking in there. So you might make something happen faster for me, but I don't feel comfortable in there because for whatever reason, one of which was I don't see individuals helping me that look like me and feel like they can relate to my experience. So I'm just speaking to how that element of feeling safe for you to perceive that an individual or an institution like a health center could be safe for you is important. Like that perception of safety is what allows one of the things that allows someone to access care in an effective way.
Yes, and I would say just to add to that would
Yeah.
be not necessarily, and excuse me, I was on a panel a couple weeks back where I talked about this, is that having someone that looks like you is not enough, because there's the old saying, all skin folk are kinfolk. So what is your mentality? Because sometimes you can you can have a dark skinned Anglo-Saxon talking to you. And the same thing that the same type of rhetoric that dehumanizes us can
Mm.
come out of a black mouth and just be like, oh, I didn't like that. So I think it's when we want to talk about diversity, I think that it's twofold. Diversity of just who you are as a person, but also diversity of thought. Because
Mm.
like depending on where you are, someone who might not look like you might be able to connect with you better than someone that does. A good example is that when I went to Tuskegee for my MPH, I grew up in the suburbs of Boston. I don't know shit about growing up in rural Alabama. So going there, it was a culture shock for me. It was like,
Right.
so how am I going to be like, how am I going to connect with people that like I don't know your experiences? It's like
Mm.
we share an experience of our overall history, us being black and being in the United States, but growing up in a rural community, I don't know anything about that. I didn't know that people like that was down there. That was the first time I ever ate deer.
Wow. I don't even know if I've had deer. How was it?
It was pretty good. They cooked it well. They put it in like a nice dip. It was good.
Ooh. Ooh, you make such a great point. I was something that I talk a lot about in public health is how we are not monolithic. I could have a sister, we could have the same parents and have grown up in the same house and be two different people completely. People are not monolithic and yes, there's this or I've noticed in the community and in myself growing up this initial false sense of if you look like me, we can easily connect with each other. And there are so many different aspects, as you mentioned, to ourselves that we can connect on. And thought is
Mhm.
so important. Thought is so important. Thought and perspective is so important.
And don't get me wrong, there are foundational things that we can connect on. And I think that's where we should always start is where do we agree on? And then from there we can grow a relationship out of that. Even if we might not have the same experiences or agree on the same things, we've already established that we have a connectiveness here, and we might just have mutual respect for each other in the sense of you believe that or you went through that, and it's like then it's like that's still a relationship, but I'm not trying to find the niche thing that from there is just like, oh well, you don't like this specific thing, so we can't connect. It was like, no, foundationally, there are certain things that connect us all. Start there and then work your way up. And that's how I think you can build, uh, first of all, just a relationship with the community, but also trustworthiness and, like you said, authenticity.
Mm-hmm.
Because I'm coming to you as me. This is all that I have to offer. We're going to connect on this. and we disagree on this, but know that I'm invested in your well-being.
I'm like, that felt so supportive. I'm like, can you imagine if providers in some way, shape, or form, whether saying that directly or in whatever way someone needed to hear it to receive it, that was said? I think everyone wants to feel that.
Yeah, I mean, it would probably change the game, but you have to have buy-in from people that are actually on the ground interacting with people.
Do you think there's difficulty in doing that, or are you just stating that it's something that has to be done? Do you think getting buy-in is difficult?
From as a public health official, on a, like getting buy-in from the community, I think it's a case by case.
Yeah.
There's an overarching, again, foundational history that connects, but they there might be some communities that are more open to interventions, and then there are others. I had the unique experience of getting my master's of public health at Tuskegee with, and I'll say my observation. I will not speak for that. Speak for the community. My observation is that there was a reservedness that they had. Whereas, like, when if someone tried to come in and be like, "Oh, like," it's like, "Oh, I wanted to do this," and it's just like, because first of all, of the historical um, maltreatment that has happened, and then with the school being there, is that a lot of times they've seen people come in and be like, "Oh, like I want to do this," but to them, it's just a project or it's a thesis, and our our mistreatment, our pain, and our triumphs are no one's intellectual exercise. So if you're not going to be authentic with it, then just don't even talk to them. So with dealing with that community, it's like I understood it, and if they said, "Hold up, don't like just back up," I would say, "Okay." It's like I'm not gonna push anything. Let me know when you need me. I'm here to help.
Yeah. Yeah. I'm thinking about a project that I worked on recently in the community, and projects are bound by how long you get the funding for, and you have funding for X amount of months, and then we want to get a report in this month, and then the funding is over and the project is over, and the deep work that you were doing to test to see if it was effective in the work in the community or communities that you were working in, um that deep work isn't happening anymore. And yes, you did a project to show that it's effective, but you've now started a process and plucked it out, so to speak, of a community because it was only time based. And that causes a lot of friction in the community as well. I'm just thinking about my own experiences and how I've tried to mitigate having funding for a specific time period that would really benefit engaging certain communities in, but how to keep the work going when the funding isn't there anymore. And I think it's hard. It's something I'm still working on. One way I've done it is there's a project that I have funding for now, and my plan is to keep the project running by hiring a lot of interns in Boston and training them. And I feel really good about that. And I think it's a way to mitigate not always having funding to carry out the work, and also effectively training our emerging public health scholars. So I think there are ways that we can be strategic and think about how to keep the action and impact happening, even when things like funding from the government and timelines don't always line up. And also, something I'm thinking about is how do we disrupt that? And that's something I'm still thinking about. I think that's more on a policy level and advocating for change in policies and laws. But it's very restrictive that funding for all these public health projects are for specific time periods. And there are reasons in terms of assessing research and work and interventions in a certain time period to try and move them along. But I think change needs to happen because that causes friction in the community when they get access to something and then it gets ripped away. One more example I'll give is when I used to have a nonprofit organization called Jamaica Me Smart, and one of the many things that we used to do in Jamaica is host a event in the community before the school year that helped students get backpack and different school supplies and everything they needed. And it was an amazing 1 year event. And in the interim throughout the year before the event, we would get requests from schools and individuals about what they needed to get. And I just feel like uh, work can't be a one and done. And sometimes when it is a one and done, it causes more harm because the community is like, okay, this is great. Thank you for doing this. And now you're gone. So this is what you're going to do the next time. So you're not going to be back next time. And um, it prevents. Well, I think different situations could be different, but in the case of research, that prevents our communities in the Black community being better understood and served.
And when I say this, I don't want to be disrespectful to anyone, but going off of what you said, the framework is what they use is that the way that some communities look at researchers, they're politicians with a clipboard. They only come around when they need something.
Yeah,
And
I
uh,
mean
it's unfortunate. And I've had while I was at Tuskegee, I had someone say to me, it's like we understand when the funds run out, the love runs out.
that stinks. Like, but that's what it's like.
And it's unfortunate. And I think that we I think the first of all, the way that we change that is that we change the paradigm of research, of what research means, because the policies aren't going to change until we redefine what research actually means. Because
Mm.
if research starts and ends at data collection, then the funds are always going to follow that timeline. But when you bake into research a level of sustainability, is that that's when it will be reflected. Personally, I feel like that will be reflected in the policies, because you might get a grant for 1 million just to do the data collection, but if research encompasses sustainability, then I might actually need 2 million because I need to set up the infrastructure for this to keep going even when I'm gone.
Yeah, there. You just mentioned that. It reminded me of an NIH grant actually that um, was released earlier this year, and a lot of people that I know in our community, including our organization, applied for it. And it's called the Compass Grant, and it um, is a $10 million
Wait, I'm sorry.
grant.
It's called what?
Compass, COMPASS. So it's an
Oh,
acronym.
I thought you said
Um,
Columbus.
oh,
I was
child.
I was
Oh
oh,
my
shit.
gosh. Woo! No. That was Columbus, Compass. Sorry. Um, so funny, but not, but funny. Um, and what I love about this grant is it offers 2 to 3 years of just planning and engaging community before collecting data. Can you imagine 2, 3 years of engaging community before asking them to participate? It provides funding to accommodate that. And then it provides more funding after continuing engagement in community. This is the first NIH grant that I've ever seen do that. And not to say that there hasn't been ever another one before. There's community based participatory research that uses different models where more time is allotted for research dissemination and action and has connections to advocacy. But there aren't many, if any other than this one that I've seen, where there is money and resources and an actual timeline that says, in these 2 years, this is what you're doing,
Hmm.
specifically with community. And that this is what you're doing is continuing to engage community and finding a sustainable way to continue some of the services you offered in the intervention. Um, we need more of those. And I what I plan to continue to do as a public health practitioner and researcher is to continue to apply for grants and carry out studies that call for that kind of funding, which might mean that there aren't a lot of funding streams available that accommodate that. But that's how we disrupt the system. We choose not to apply, which is like, oh, there's not that many out there, but we choose not to apply to funding streams that don't allow us to thoughtfully do this work. And unfortunately, that's many funding streams. But that's how we make change, I think.
I agree with you, and I think it's not either or; it's both and.
Mm,
And I
yeah.
think that with sustainability, it comes from the policy side, but it also comes from the community side. There's um there's a lyric from what's this Jidana, and in one of his songs he said, "If we spread the wealth, we can do it on our own."
Mhm.
And I feel I feel that if we can get the buy-in from the community and find a intentional and very just clear-cut way of funding our own programs, is that to a certain extent, it's like the grant money, we're never going to say no to grant money. Grant money's
Right.
good.
Okay.
But we don't become reliant on the grant money. And
Right.
I really believe that I really believe that the capital is there. I mean, just looking at just the numbers, like as a black community, we have over $1 billion spending power.
Where?
A lot of
So,
times, it's not what you're doing; it's how you're looking.
mm, mm. That goes back to the beliefs, I feel like. Hearing you say that yeah. Thank you for that. Yeah. Yes.
Yeah.
It's how you are looking. So many gems today. Yeah.
uh, well, I don't want to hold you up too long, so I have a couple more questions for you.
Ah, sure.
Um, so I guess where do you see the future of public health going? Public health slash health. Well, actually, no. Before that, the one thing we do need to tease out. Um,
Sure.
do you think the healthcare system adequately addresses like the people's health needs?
No,
Okay,
it doesn't.
there we go.
Yeah, and I'll say more. I don't think the healthcare adequately addresses people's health needs, because it's not built to. Unfortunately, I think there is rebuilding that needs to happen in our healthcare system that will allow for people's disparities and inequities to adequately be addressed. One of which is what we surfaced earlier in the conversation, which was asking people what they need,
Hmm.
what their priorities are. Um, just thinking about triage questions when I go in for whatever, there is, like, I would love for one of the questions to be like, what's your greatest need today? Or I like something like that. And maybe there are some institutions that do that, and great for y'all that do. Um, yeah, yeah. The system needs to change. The way the system works and how we do things in this system needs to change to adequately address people's health needs.
And I agree with you on that. And I believe that we don't have a healthcare system. We have a sick care system. That people
Ooh,
pe-
yeah.
people only interact with this system when they are sick. Think about it. What's a physical? You go to the doctor and they're looking for something. If they don't find anything, they say come back when you have something I can find.
Mm. I think I think that's some people. And I'll share with you the visual that came up in my mind when you said that. When you said it was a sick care system, there were people that popped up in my mind like, oh yeah, like, you know, people go just to the emergency room or they're doing to address things in the immediate. But there are people in our population who are very much going for preventative care. Like they have their once a month for whatever they need once a month appointment or every 6 months. So I guess I'm offering that to say I think
Well,
there are some people in this world who do experience it as a healthcare system and others more as a sick care system.
I would push back on one thing.
Yeah.
Your daily, well, not daily, your monthly checkup or your 6 month checkup is that when you go there, are they providing information to promote your health, or are they only looking for disease?
It depends.
That's
What it Yeah, it depends. Like if it's a behavioral health or mental health appointment. I'm thinking about, okay, so things at Fenway Health. We have medical, dental, vision, behavioral health, public health prevention programs. We have a needle exchange. So I'm thinking there are some services where it's just like, great to see you. Let's check this. Like, let's keep in mind with this. And others where it's like, we are looking for this specifically. And you're not just here to like check in with us. I want to think deeply about that too, deeper. But yeah, I think it depends what kind of care you're receiving. Um, and I think it's more that people are the recipients of care that address dis-ease in their body than um, general maintenance and prevention. So what I'm saying is, I feel like most people experience the system as a sick care system.
mhm.
Um, well, I do think some people, and based on what services they're getting, they may experience that healthcare system. Yeah, my doctor's great. Yep, we just checked in. Yeah, nothing was wrong. But you know, I like to just make sure everything's set. I don't know who I was trying to be in that example, but
But
yeah,
I think we got it. Like with
yeah,
that
yeah.
voice, I knew exactly who you were, but I no, and I agree with you. I just, and maybe it might be just semantics, but I think that words hold certain power.
They do.
So if I say I went to my doctor and nothing was wrong, that's different than I went to my doctor and this is how I can be better. Because I think that a lot of times when we approach health, we look at it from a deficit model, not an asset model. We look at it as just like, is something wrong? Versus just like, how can I be better? How can I
Mm.
keep going forward? Because for me, health is not a destination, health is a journey. It's the road, it's the pavement on the road that gets us to where, like, to the things we want to do. And for that, it's just like I'm not gonna look to see like, oh, are there any potholes? It's like I'm looking to make sure that this road is as pristine as I can make it. I'm not waiting until a pothole comes up. I'm doing, like you said, preventative things to make sure that my road doesn't have potholes.
Yeah, that just hit me. I know we're wrapping up soon, but it just made me think of a journey that I had. I used to struggle a lot with a chronic pain disorder called fibromyalgia. Have you ever heard of it?
Yep.
And um, I'm thinking about just all my doctor's visits and everything now, and they were very much centered around like sick healthcare. Um, and I remember when I took my care into my own hands, I still continued seeing doctors, etc. But I realized I needed to take control to create a system of health for myself. And so I was taking a look at what my thoughts were. I was being more active. Like I was addressing my health in ways that weren't at the time being addressed by my doctors. I think about my doctors now, and I don't struggle or suffer with that at all now, gratefully. But I look at my doctors now, and I can talk to my doctor about Reiki, which is energy healing. I can talk to my doctor about yoga that I do. But when I was coming up and experiencing fibromyalgia, we weren't having those conversations. It was, here's more muscle relaxers and etc. This is what your levels look like. It was like it. So just to your point, I'm just really thinking back and resonating like, yeah, it makes a difference when someone is speaking to you and addressing your whole health and how to maintain it and make it better, and not make it better, and not just addressing whatever dis-ease is presenting in your body. Because then your understanding of the institution of a healthcare center or a hospital is always to address sickness and not to build wellness.
Yes. Yes.
Mm-hmm. Mm-hmm.
So, just saying, just
Yeah,
different, I think it's a different paradigm that I think is essential if us as public health practitioners, officials, whatever term you want to put on us, we care for the people. We're trying to make the public healthy. And with that, I think that is, like I said before, the community defines its own health. That's why that sometimes when I get into conversations with people about health disparities, they're like, if you're looking at it from a statistical standpoint, there's only two ways to fix health disparities. Because white people are used as the standard, it's either white people get sicker or black people get healthier. And
yeah, but I just like, ew, but yes. Yeah.
and I disagree with that paradigm, because with that, it's still centered around how sick someone is. I don't want to be as sick as a white person. I want to be as healthy as I can be.
Mm.
And so when we talk about health disparities, health equity, it's just like we need to be very intentional. It's like, what does that mean? Are we just as sick as someone else, or are we the healthiest that we can be?
That's so good.
But
That is so good.
I'm gonna stop preaching. So,
No, it's so important. That's so important.
but my last question is a question I always ask. I always ask for some parting advice from the guests. Is that so? What advice would you give to people that are either thinking about getting into public health or are freshly into it and trying to just navigate these waters, especially Black public health officials?
A couple things. One, I would say to be open. Public health is really broad. And we started this conversation by saying, public health can fit into and relate into any aspect of life. And being open helped me really find what I feel like is my space in moving the work forward. I feel like we all have a space, and all of us being able to find it is what will allow us to move the work forward. And so just being open to different experiences. I did so many internships, and like just explored different opportunities, read so many different things just to understand what I connected most with. And it was really the experiential learning that helped me. So actively being in an internship, participating in something, those were the most impactful for me to understand what I wanted to do in the work that I was being connected with. And specifically as a Black professional in public health, one is find your community. And this can be individuals that find your community within, and that can mean anything. It doesn't just mean your Black community, but find your community that helps you feel empowered. We've been talking about empowerment. And I think it's it's hard to be a public health professional, especially a public health professional that has one or more marginalized um, identities. It's hard. So, like, finding your community, finding a mentor, and also caring for yourself. Like, when I talked about earlier doing all the work of COVID-19 and blah, 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 it was so exhausting to be in rooms to hear people say, oh, we need to get with the Black people. How are we going to engage the Black people? I was like, damn, I'm in this room and you're talking about me. I am Black people. I am me. It could be exhausting to work in communities where you're seeking to um, build wellness. Because um, if wellness needs to be built more in the community for which you identify, it's hard. It's like pulling on heartstrings. We mentioned earlier, you're hearing these statistics and numbers, and you're seeing your aunt, your uncle, your mother, whoever, whatever loved one, and it's harder. And so, just an openness, the three, I would say, an openness to connect to whatever area of public health that might be best suited for you, and be open to how you might find that. Might not get it right away, or you might. To finding your community and really connecting with a mentor or just people who can help build and motivate and empower you, because we need to be empowered individuals in this work to support and help empower the communities that we're seeking to help. And that piece about self-care and just self-compassion, this work is really hard. And so take time to like tap out. Like, it's okay to not be resilient as a public health professional. Like, I'm exhausted. I'm taking a half day off. And sometimes we can't take a half day off depending on our role. So I just want to like own that. It's not always a possibility, but just we can't help anyone if we're not helping our own selves. So I just extend that to our public health professional colleagues.
Thank you. Thank you. And please, if you can, take a mental health day. If you can, go like see a therapist. It might not have to be every week, might not have to be like, if you need to go, because I like you said, it's exhausting. It can be very draining sometimes, and it can weigh in your mind, because when you look at the elephant, it's hard to envision yourself eating it, but
Mm.
but you have to eat it one piece at a time.
Absolutely. And just on therapy, I'm in therapy once a week. I love it. And my therapist is a person of color, and it for me that's just so helpful because I can go in and just be like, white privilege, blah, 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 like structure, and just like process out whatever stuff I have going on. So, oh, yes, that really helps me stay grounded and um, process and be in a place where I can respond in ways that um, are in alignment.
Yes. Well, I want to say thank you again for coming on. I think I'm probably gonna have you back because there's
I'm with it. I'm with it. I'm so with it.
there's a decent amount of because I sent you the questions. There's a decent amount of questions we didn't get to yet, but
I'm into it.
it was a great conversation. I want to say thank you again.
Thank you so much.
And before we go, are there any upcoming events that you want to let people know? This is going to be posted this Tuesday. Let me get the right date, the 25th. So, are there any upcoming events for your organization or anything like that that you want to let people know about? And also, if people want more information, how do they get in contact with you?
Yeah, absolutely. Our organization is popping up around um, Dorchester and Rosendale in the months of May and June to help people with COVID-19 vaccination, but also to have conversations about them, about what prevention means for them and what treatment means for them and what they need access to. So that's happening up around the city, and information about that and other things that we have going on can be found at fenwayhealth.org. We have a lot of different pages related to our services. So I encourage folks to take a look at the website and see what they might need. And also to visit the couple other links, the Massachusetts League of Community Health Centers, different health centers that exist across the state. So I think anyone just having access to whatever is closest to them is really important. But our organization, funwayhealth.org.
Okay, well, thank you. Thank you.
Thank you.
And everyone, that has been another episode of Tomb Talks with the Pharaoh, and I'll see y'all next week.